Tom, let's say you have a patient. Now you've got, let's say you're in a place where there's no clinical trials, and that's a very sad place to be, but there's no clinical trials available to you. Does the approval of MM-398 maybe make you think more like Kai was talking about when we're thinking about sequencing? Does that change what you would do in the first line? Or would you do things differently? How would you?
I think that it can't help but color your the way you think about treatment, knowing that you have an approved regimen in the second line that closely models drugs that you might think about in the first line. So if you have a patient that you really have clinical equipoise on whether you're going to give them FOLFIRINOX or gem-nab-paclitaxel, based on the fact that there's an approved effective regimen in the second line, I think that does steer you closer to gem-nab-paclitaxel and away from FOLFIRINOX. And you know, I don't think you can do that for every patient. Some patients who are you feel that they really would benefit from a regimen such as FOLFIRINOX, where you might get a really explosive response and maybe downstage them or something to that degree, I think is still on the table. But I think that this will ultimately impact the use of gemcitabine and nab-paclitaxel in a positive way. And based on that, I think I'll be using more of gem-nab-paclitaxel in the first line, knowing that there's going to be an accepted doublet in the second line.
Yeah. Philip, what do you think? Where's your treatment continuum now? Now we're talking, it used to be colon cancer, now it's pancreas cancer.
Yeah, I agree with Tom. Again, I'm a believer in more moving to the tolerable doublets and moving them along. One thing I have to make a comment on is FOLFOX. And we use a lot of FOLFOX as second line. And also it's used in the community, FOLFOX or Zolox. But if you look at the data with FOLFOX, really it's not consistent. Yeah. In fact, the OFF, which was the initial trial, which we interpreted as FOLFOX, it was positive, but if you look at the curves, they're really very close. And then the Canadians presented a study in 2014 at ASCO, where they showed, in fact, FOLFOX itself was worse than 5-FU-leucovorin in the control arm. And we had also experience in SWOG. We had a study in the second line, and I can tell you the performance of FOLFOX wasn't really that good. So we have a study which shows benefit, although again it's a modest benefit. So we have to think of that as being, for a time being, the best evidence we have, and to use that, then the best sequence will be to use gem-nab-paclitaxel on the front line, and then move on into a regimen such as the one used in Napoli-1 study, which makes sense. And also you're removing the risk of the exacerbation of neuropathy, because you're not going to use a drug that will affect that. So I think it's a nice way of sequencing, which makes sense based on evidence. The key thing is based on evidence. And in fact, in the Napoli-1 trial, there were some patients even had received irinotecan in the front line as a combination with gemcitabine. If you look at the breakdown of the prior therapies.
So would you ever then use FOLFOX third line?
I personally, I mean, that opens up the discussion of what's the philosophy of using second, third line treatments. Yeah. There is something about second line, third line, which there's a feeling that I sit with academic oncologists, and they tell me, GI oncologists, Dana Farber, MD Anderson, Sarah Cannon.
Thank you.
So I always hear about in advisory boards, and people say, oh, more than 70% of my patients go in second line. Well, wait a second. 70% of patients who come to MD Anderson or my institution get second line. That's not the real world. If you look at the clinical trials, even like MPACT, even in those trials, which were patients who went on first line clinical trial, so they're different than the average patient. 50% is the maximum you see people going on second line treatment. If you go to the real world, community patients, it will be like less than that. Maybe 20-30% can go on second line treatments. It tells you something. Number one, those patients really aren't that, the majority are very still compromised by the disease. But the fact is that in the second line treatment and third line probably, the chance of cytoreduction and getting a good response in those patients and a good PFS is really very small. So what becomes important? Quality of life.
Yeah. Very good.
So do I want to use FOLFOX in the third line? Yeah, I can use it maybe in an odd patient who's doing very well because of biology, but it will not be my recommendation.
I want to brighten things up a little bit. The
Yes.
first and the second line in the community can be high, can be 60, 70%. I think maybe they're switching regimens a little early, but in the clinical trials it's typically 40 to 50, but you can get more people going first.
Well, I meant patients who are able to take combination treatment. I mean, you can always, sometimes people give first line, second line, and then third line, they give the patient capecitabine single agent, just saying that I'm treating the patient. Now that's placebo for me.
Yeah, I agree with you. We don't even know if the drug's absorbed. But the other thing about
I hope you
the
don't
sequence,
do that. You're in the community.
Wow.
Well, partly, so there you go. But the other thing about the placement of Onivide is the lack of neuropathy and the lack of thrombocytopenia, which you see with the FOLFIRINOX and the nab-paclitaxel gem regimen. So you kind of have a period of rest for the patient in the settings of neuropathy. So that's good.
So does it influence now? Are you using more gem-nab because you've got the MM-398, or do you?
I will be, yeah, absolutely. So I think it's a very thoughtful sequence, and again, you can always come back. I agree with what Dr. Phillips said in regards to oxaliplatin. The data is just kind of soft right now, and you know, that's going to be challenging to use.